Hi, I'm at Ascension St. Vincent. Joining us today is Dr. Ghoneim, who is a urologist here, and we're talking about prostate cancer, all things prostate cancer 101. What is it that we need to know about this disease affecting men?
So one of the biggest things to know about it is that it is one of the more common cancers in men. It tends to be ranked very high as a prevalence. However, it is a cancer that we can screen for. And so screening for prostate cancer is relatively simple. It involves a blood test called a PSA, and that is something that can be started roughly around ages 45 to 50, depending on the risk level, previous family history, and so on. But it is relatively simple to screen for prostate cancer, and once we have a diagnosis at an early stage, there are many treatment options for it.
So there's that blood test, but there also is the physical exam, and I think that's what gets a lot of attention and maybe perhaps keeps a lot of men away.
So that is one of the things that the media hasn't done us very good service of telling stories about prostate exams. However, the prostate exam can many times be dictated by the blood test, and so my message is don't worry about it. It is part of the physical exam. However, doing the physical exam can make the whole difference between finding a nodule that can be managed very early versus just letting something fester and grow. And so please get started with PSA screening, and then let the PSA screening dictate how things go from there.
Okay, so with the blood test, what are the numbers that you're looking at that cause concern? And then maybe also talk about, as those numbers change, the significance of the rate of change as well.
Great, so that is a good point. PSA is one of those markers that has a normal reference range. However, it is a very loose reference range because it applies more to the clinical setting. So the typical value that a man may see when their labs come back is from 0 to 4, considered to be normal. Anything above 4 can be further worked up. However, the primary care doctor as well as the urologist need to weigh in on that result. And so it can change as well with age. And so we sometimes accept slightly higher PSAs for older age ranges. One of the concepts that we look at is what's called PSA velocity, which is how fast it's going up. And so that may be an indicator that it's not just going up because the prostate's getting larger in size, but because maybe it's harboring something else. And so PSA velocity is one of the concepts, how fast it's going, a doubling rate of PSA. But in general, let the medical professionals and the urologists do the interpretation of the exact number.
And then the next step is, if you have a number that your medical professional says, yes, we've determined you have a cancer, what are the next steps? What are the common treatment options and the next steps of like, oh my gosh, I got this call, I saw this number, now what?
And so if the PSA is found to be in a range that is concerning, most likely what will happen is primary care will refer you to a urologist. The urologist will then have an office visit, conduct a history and a physical exam, and then most likely the next step will be a prostate imaging or prostate biopsy. Those are the definitive tests that help us further define if there is truly a prostate cancer. It helps us look at where it is in the prostate as well as its stage and grade. And then the next step would be to have a conversation about treatment options. And the treatment options are quite multiple. The treatment options range from active surveillance, where the individual chooses to monitor the cancer, and monitoring the cancer means that they are under the care of a urologist, getting frequent PSAs and examinations to determine that the cancer is not changing in character, and if it does change in character, then we have another conversation about what to do there. Then we have treatment options that are what we call definitive treatment options, meaning to get rid of the cancer. And those are kind of two big arms. One arm is surgical options, which is most days, or most of the time nowadays, is a minimally invasive option, robotic or laparoscopic radical prostatectomy. And the other arm of that definitive treatment option is radiation.
Yeah. What are the things that patients are considering when they're making those decisions, and how much of that is guided by you and how much of it is guided by the patient?
So we kind of follow a model of what we call shared decision making. So it's not up to either one of us to make that decision alone. We come to the decision together, the patient and the urologist. A big part of it comes down to whether the patient would like to have a surgical treatment option versus to undergo radiation or to undergo active surveillance. One of the slight misconceptions is people tend to think, well, radiation is kept for cases that are not for surgery, or radiation is kept for cases where surgery is not enough. However, in the realm of prostate cancer, radiation therapy is a definitive treatment. It is sufficient to eradicate the cancer, albeit not through a surgical method. When we talk about the surgical options, we have to have the conversation about what the surgery means, what it is that the surgery involves, the scope of what is being treated. The prostate, the seminal vesicles, and those are the main focus of the surgery, as well as some of the expected effects of surgery.
So in this shared decision-making conversation, sexual function is a big important part of that. Mm-hmm. What do you see as far as prognosis of a return of sexual function between these different treatment options?
That is a great question, and yes, it is definitely one of the major talking points. So with the surgical treatment option, one of the developments with the surgical technique is we also are able to do nerve sparing, provided that the cancer is in a location that allows nerve sparing, whether it's nerve sparing on one side versus both sides. It really is dictated by the location of the cancer. And once, in patients who undergo nerve sparing prostatectomies, return of sexual function is very predictable. It does take a while to return. However, the return of sexual function is more or less going to happen. In cases where nerve sparing is not possible, we then have to prioritize what we call oncological efficacy of this treatment, because we are, at the end of the day, trying to treat a cancer. So that would take priority at that moment. With radiation, sexual function tends to return a little bit faster. Radiation does not involve, damage to the nerves. However, radiation of that field can delay return of erectile function to a certain extent.
Yeah, that's a very important and sensitive conversation,
isn't it? It is. The biggest thing is it has to happen within the context of the one-on-one interaction with the shared decision-making, because having that conversation or reading about it, just plain numbers, okay, this is the percentage of this and this is the percentage of that, doesn't necessarily translate into the individual unique case. And that's why the model of shared decision-making is so important, because it allows the doctor to relay the information to this particular patient for this particular case and allow the patient to have all the information necessary to make a good informed decision.
With the screening that's available and covered by insurance and things, it must be very frustrating for you to see somebody who's presenting with a late-stage cancer. You must feel like, man.
Mm-hmm. That is true. One of the things is we need to always make sure that we follow the guidelines for screenings, whether it's prostate cancer or even colon cancer, breast cancer. Any cancer screening guideline is there to allow us that window of early detection, because early detection makes all the difference. It still allows you to make a lot of options available to the patient. And so you are right, when we have all these tools at our disposal, we need to make sure that we utilize them so that early screening is accomplished. One of the things that we also need to make sure is that we still allow early screening to happen by maintaining that minimum level of coverage for everybody to pay for these screenings, because catching cancer at an early stage will make all the difference between whether we are able to eradicate it versus dealing with late stage, which has symptoms and has metastases and all these other things.
Yeah. And before we wrap up, I do want to address those that are most at risk, so people know, is this me? Or are you talking about me?
Okay. So anybody who's had a family history of prostate cancer has a slightly higher chance. In our population as well, as we start to cross the 45 to 50 mark, that prostate cancer screening is much more recommended at that age. The African American population definitely recommends screening starting at that age as well. But mostly, all males should, above the 45 to 50 age mark, should be screened for prostate cancer.
Yeah, and overcome the barrier, overcome the excuses, just get it.
Absolutely. Don't be, anticipating something bad. It is just part of routine health screening.
Yeah, just get through it.
Yeah,
All right.
absolutely.
Thanks, Dr.
Thank you.
Ghoneim. We
Thank you very
appreciate
much,
it.
and thank you for spreading the word.
Yeah.
Great.